Welcome to ATCM, the Emergency Medicine channel.
Yes.
So today we'll be discussing about the chapter in ATLS of shock. In that chapter, we'll be describing about the last part in the adjunct. It's mainly about the massive transfusion protocol. Today we'll be discussing
in
about
ATLS, there is a chapter called shock, and towards the end of the chapter, you have got a area for additional reading regarding massive transfusion protocol.
Yes.
That is the topic which we are going to discuss here. Strictly for emergency medicine PGs or surgery PGs, or those who are interested in learning more about ATLS.
So today, sir, I'll be discussing about the ACS guidelines of massive transfusion protocol in trauma, which is the American College of Surgeons guidelines. According to ACS, the hemorrhage is the most common cause of death within the first hour of arrival to a trauma center, same as in ATLS. So the massive transfusion protocol, so MTP should be a written document, and it should be accessible to all and adopted by the center. So it should be a specific for a center is what is said by the ACS, and all staff should be familiar with the procedures in the ACS, in the MTP guidelines. So the content of the MTP protocol, it should be based on the principles of damage controlled resuscitation. As such, there should be a focus on the ratio-based blood products administration, and which must be empirically delivered, so that there is and the immediate availability of the RBC, plasma, and platelets. So this is mainly the focus of massive transfusion protocol, and the protocol should also include the standardization of the assessment of coagulopathy, and also should include assessment and treatment of associated factors which can lead to the death in case of trauma, like in acidosis, hypothermia, and even hypocalcemia. So massive transfusion protocol should be developed by a multidisciplinary team, is what ACS says, and should include at minimum representatives from transfusion service or the blood bank, and should include the emergency department, should include anesthesia and also trauma service. And so these four departments must be involved in the formulating of the massive transfusion guidelines in each trauma center. So
basically, massive transfusion protocol should be initiated for class 4 hemorrhagic shock.
Yes.
And this protocol should be made on a jointly by the emergency physicians, the transfusion medicine doctors, the anesthesia,
and the trauma service.
There should be a protocol, like if this much of amount of blood is lost, what should be the protocol for blood transfusion?
Yes.
Okay, there should be consensus regarding how much RBC to be given, how much plasma to be given, how much platelet should be administered, things like that. Okay.
So the massive transfusion protocol, it should address the following factors. The first one should it usually addresses the triggers for initiating a massive transfusion protocol in trauma, and the resuscitation in the trauma bay, which includes the MTP product availability, MTP product delivery, and also the MTP blood product transfusion. So, and also whether we should the criteria for continuing the MTP in the in the angiography area or in the intensive care unit, in the ICU, and also what are the transfusion service processes for the delivery of blood products, and the transfusion targets, and also the use of adjuncts for MTP, and also for the termination of MTP, and also the performance improvement monitoring. So all these factors we are usually which we'll be mainly discussing about. So the triggers for initiating massive transfusion, it's usually we document it by a well-validated scoring system. It's called the ABC score, the Assessment of Blood Consumption Score. It consists of 4 variables.
So that is important. ABC score. Whenever a question is asked on it, it will be an essay question or a short answer question. Massive transfusion protocol. So this ABC score has to be mentioned.
Yes. So the ABC score contains of 4 variables. The first one is a pulse. So the pulse of the patient, if it's more than 120.
What are the pulse? BP?
Pulse, BP, and fast positive, and penetrating torso injury.
Okay.
So all these
4 points. Okay.
And
to
so,
the first point.
So if pulse is more than 120, or the systolic BP less than 90, or fast positive, or if there is a penetrating torso injury. So in these 4, minimum if 2 is positive, we must initiate massive transfusion protocol. So that is the usually the criteria which is involved in the same.
So any problem in the heart rate or BP, heart rate more than 120, BP less than 90, or if the fast is positive,
or there is a
penetrating
torso injury.
So everything is in C. When you do the C part of ATLS primary survey only, you'll get to know whether massive transfusion protocol should be initiated or not. So once you assess the C completely, ultimately you say activate massive transfusion protocol.
Yes.
Got it, no?
So
that is your response. Like when after assessment, you respond. So the response is activate MTP.
Yes. Okay. So the criteria to trigger the activation of an MTP should include actually the one or more of the following factors. As mentioned before, the ABC score of 2 or more, and also if the patient is having a persistent hemodynamic instability, and along with active bleeding.
I didn't get it.
Yeah. So this is mainly.
Once more, what is it?
Yeah. So the criteria to trigger the activation of an NTP, as mentioned before, I have told about the ABC score. Like other than the ABC score, we must also add upon 3 more factors for the activation of MTP. So that they have mentioned about persistent hemodynamic instability is what they have mentioned, despite resuscitation with fluids, and active bleeding which requires an angioembolization, and also blood transfusion in the trauma bay. So these 4 are the criteria which are required for the activation of MTP is what they have mentioned, along with ABC.
So those ABC score, what should be the minimum score?
ABC should be minimum 2.
Minimum 2.
Yes.
If that is there, you can activate MTP.
Yes.
Right?
Along with that, we must include all these 3 criteria also.
Other criteria should also be there, apart from ABC.
ABC. Yes.
Okay.
So, but they have told that it should include 1 or more of the following. So even if ABC score of 2 or more is met, that is enough for initiating a massive transfusion protocol.
The problem with ABC is that unnecessarily you will be activating MTP.
Yes.
Because it's very this thing. But the thing is, you will never miss this thing.
Yes. So
Patient who really requests blood transfusion if you assess ABC, but unwantedly also you will start
MTP.
Activating MTP.
Yes.
So for that you add further
criteria.
Yes. All right. And those are the criteria.
Yes. And so next is about the blood product resuscitation in the trauma bay. So what all we use as the blood product resuscitation. We can prefer a universally compatible RBC, which is a O negative or O negative and O positive, and thawed plasma. So thawed plasma should be immediately available and ideally stored in the emergency department of a trauma center. And in areas where if patient is having a transfusion service is unable to provide this AB plasma, then we can even use low anti-B titer A plasma can also be used for thawed plasma transfusion. And
so O negative or O positive blood
along with
thawed plasma to be stored in refrigerator.
Yes.
Okay.
And for maximum effectiveness, we must the damage control resuscitation principles, the DCR principles, suggest that the RBC and plasma should be delivered by a rapid transfuser and through a blood warmer, because to prevent hypothermia.
So ideally, you should have a warmer here for any trauma center. You should have a warmer. It's not like straight away you take it from the fridge and give it just like that.
Along with
that is only for RBC and plasma, not for platelet and all.
Yes.
Pardon.
Yes. So they have told that for RBC and plasma transfusion, a rapid transfuser along with a blood warmer. So it is necessary for the transfusion, and the initial rate of transfusion should restore the perfusion, but we must always look to maintain a permissive hypotension, so that till the process of angioembolization or till the bleeding stops. So that's what is they're told about protocol. And as sir mentioned before, the platelets and cryoprecipitate should not be administered through a blood warmer. So these two components should not be administered. And if these MTP triggers are met, we must always...
so in a trauma case, basically you have got only warm crystalloid, then comes PRBC, FFP, platelet, cryoprecipitate, and then?
So these are the components, blood
components that we transfuse.
Yes. So if MTP triggers are met...
prothrombin complex concentrate, PCC.
PCC. Yes.
Okay. All right.
So if this MTP triggers, as mentioned before, that are met, usually we must begin universal blood product infusion rather than crystalloids or colloid solutions. So blood is preferred compared to the crystalloids and colloid solutions. And also we must make sure, according to ACS guidelines, they have told that the transfusion of universal RBC and plasma in a ratio of 1:1, between 1:1 and 1:2, a ratio between 1:1 and 1:2.
Plasma is to RBC.
Plasma is to RBC, yes. RBC, plasma is to RBC. Yes.
Correct, no?
Yes.
Plasma is to RBC in a ratio between 1:1 to 1:2. Or 1:1.5, 1:1.5 is also okay.
Okay, yes.
It's a ratio. It should be between 1:1 and 1:2. Plasma is to RBC. It's not like the reverse. RBC is to plasma.
That's one. Plasma to RBC ratio. Yes. And they have also told that to transfuse one single donor apheresis platelet or SDP or a RDP for each 6 units of RBC is according to the ACS guidelines. According to the now latest
for every 6 units you give RDP or SDP.
Yes.
Like one unit.
Yeah, 1 unit is SDP or 4 units RDP. So based on each 6 units of PRBC is what I mentioned. And for blood products should be automatically sent for in the established ratios. And the goal is to keep at least one MTP cooler ahead for the duration of the MTP activation. They have told that mainly it is they have told about MTP coolers. So MTP coolers they have mentioned for the blood transfusion. They have told that they need MTP coolers to keep the store the RBC, the blood products. Previously only kept blood products must be stored in a blood cooler. So they have told to keep the blood coolers always prepared for massive transfusion. So that they have mentioned. And yeah. So next is about the massive transfusion in an ICU. In an ICU, they have mainly mentioned about the attention should always be maintained, kept to correct the factors that exacerbate the coagulopathy, including the hypothermia, acidosis, and hypocalcemia. Because initially, all the initial blood volume resuscitation has been done in the trauma bay and the ER. So in the ICU, mainly the massive
hypothermia, acidosis, hypocalcemia, everything has to be dealt. That's just like for any routine trauma case.
Yes. So in ICU, it is mainly the blood transfusion is mainly based on a goal-directed therapy. It is mainly based on upon ICU reaching the ICU, we must look for the laboratory parameters. So only after that we will be mainly focusing on the blood transfusion. So the following components are usually always assessed in the lab and which must be repeated hourly. In an hourly basis. So it's mainly
because we want to know whether to end the massive transfusion protocol or not,
or to continue in the ICU.
Whether to continue or whether to end.
Yes. So they have mentioned about the INR, the APTT, the fibrinogen level, the hemoglobin or the hematocrit, and the platelet count, and the point of care testing of the hemoglobin, along with thromboelastometry and rotational thromboelastography if available. So that's what they have mentioned about the various, and also they have mentioned about ionized calcium and also the blood gas including the base deficit. So all these parameters are usually which are assessed in the ICU on an hourly basis for the need of a blood transfusion. And so the use of this, we have told that it is said that the use of empirical fixed ratio of blood products, as mentioned before, should be followed in the ICU until the bleeding is controlled or the specific laboratory and point of care data is available. Till the point of care data shows a
either the bleeding should be controlled or the lab parameters should be
normalized.
Normalized.
So
either it should be bleeding anyway should be controlled.
It's and
or is it like or?
It's and or. Yes.
Okay.
So they mainly mentioned
about bleeding should be controlled. On top of that, lab parameters should also be normalized.
So that's when
we should consider the permissive hypotension aspect also.
Yes. So these are the basic goal-directed therapy, the massive transfusion protocol guidelines which are done in the ICU. Next is about the transfusion service or blood bank, how it should be present in a trauma center. In a designated trauma center, it should have an on-site transfusion service that operates 24 hours a day, 7 days a week, and has a specific operated procedure for the rapid, early, and continuous delivery of blood products. And they have also mentioned that the most efficient way to immediately initiate an MTP is to have a blood refrigerator containing a universal donor products in the resuscitation bay. So that's what they have mentioned in an ideal trauma center.
It should be in the resuscitation bay itself, not the blood bank.
Yes.
It should be the red area itself. Okay.
Yes. And so these are the mainly they have told about. And they have told that currently RBCs can be safely stored up to 6 weeks and are released using a first in first out system to minimize the wastage, so that there only one PRBC at a time according to the issue is what they have told about. And for an MTP to be effective, they have told that the universal thawed plasma should be immediately available. But usually, ideally, it's not available in all the centers. But they've told that for the MTP to be effective, universal thawed plasma should be available, immediately available. And this is usually accomplished by storing thawed or liquid plasma. So the ideal universal plasma is AB plasma. But unfortunately, it is short supply. So that's why we can use even anti-B titer also we can use. So that's what they have. Anti-B, yeah. Anti-B blood group also we can use in the case as plasma if AB blood group is not available.
So plasma is AB blood group.
Yes.
Blood is O negative or O positive.
O positive. Yes, sir. So these are mainly they have told about, and they have also told about the following blood products should be kept in hand by the trauma center in the case of a like massive trauma initiator of an MTP. A designated trauma center should have the following things in hand: at least 8 units of universal donor or uncross-matched RBCs. They have told as an example of 4 units of O negative RBC and 4 units of O positive RBC. So
that should be in the refrigerator.
Yes, in the refrigerator always kept ready.
4 O negative, 4 O positive.
Yes.
Blood should be there.
And at least 8 units of thawed group AB or low titer anti-B group A plasma.
Okay.
So that also they are told to be kept in. Yes. And additional plasma should be obtainable from the transfusion service within 15 minutes of MTP activation. So that is also one of the criteria that must be met. And uncross-matched blood products should be delivered until the group-matched products are available. And once the transfusion service has received a blood group specimen for group matching, group-matched products must be available within 10 minutes. So that's the guidelines they have told for the blood bank. Usually, after getting the group
that is matching, for the blood bank, not for ER doctor.
Yes,
their protocol. Okay.
And also it's told that the cross-matched RBC should be available within 1 hour for most patients. And notable exceptions they have told, because some patients may have an RBC allo antibodies. So in such case, patients or patient is having a rare blood group. So in these two situations, we may not need for an RBC to arrive within 1 hour. But otherwise, in a designated trauma center, the RBC should be arrived within 1 hour.
They are telling how a trauma center should ideally be like.
Yes.
Okay. Otherwise, you can't call it a trauma center.
Yes.
If you don't have these facilities, just refer the patient to a trauma center. That's all.
So this is next is about the endpoints of transfusion. So endpoints of massive transfusion, it is mainly based on.
This is important. The endpoints of massive transfusion protocol.
So mainly it is based on guidelines from proper trial. Proper trial mainly the pragmatic randomized optimal platelets and plasma ratio study. It is also the criteria is mainly for stopping the MTP should be both.
Proper trial used to come as a recent advances when I was doing my PG.
Yes.
Proper trial.
Proper trial. Okay. So proper trial is
crash 2 and all these crash trial and things like that.
Yes. So transaction case. And the criteria for stopping an MTP is usually includes anatomical criteria and physiological criteria. So anatomical criteria is the control of bleed. That is the first criteria, and physiological is the normalizing the hemodynamic status. And so the decision of to stop should be made by the trauma surgeon in conjunction with the anesthesiologist if the patient is in the operating room, or intensivist or trauma surgeon if the patient is in the ICU. So that is who can stop the MTP is what they've told. And so in the operating room, as mentioned before, they have told that the goal directed therapy, as mentioned before in the ICU, the following parameters I have mentioned before regarding the PT-INR. So all those parameters, if they are getting normal, or if there is a like physiological evidence of bleed control with hemodynamic instability, and if there is control of the bleed by angioembolization or stopping of bleed, we can stop MTP is what they have told about as guidelines.
So basically, once bleeding is controlled, and anatomically once bleeding is controlled, or once physiologically once all the heart rate, BP, everything is normalized, or if the endpoints of blood transfusion, including that lab parameters are achieved, you stop MTP.
And MTP should also be discontinued when there is recognition that further resuscitation is futile. If in case even after giving the following things I have mainly told about, if RBC transfusions even giving starting a massive transfusion,
but it is not
reviving, then we can stop an MTP is what they have mentioned about. And
have they mentioned after what time they're like?
No, they haven't mentioned about the time limit actually.
So after giving all the blood products, all RBC related everything, still vital, like condition is not improving, then it's futile to continue with further resuscitation.
Yes. And the following things should be guide as like I am just elaborating about the previous things which I mentioned before. Anatomically, if patient is not bleeding, and they have also told that in the active resuscitation phase, if RBC transfusions are done for HB more than 10 gram per deciliter, and also if a plasma transfusion for a PT, if a PT, the prothrombin time, if it is less than 18 seconds, and an APT.
These are the endpoints, right?
Yes. Endpoints.
You should make, your idea is to keep HB more than 10 or more.
Yes.
10 or more,
HB more than 10.
More than 10 or 10 or more?
More than or equal to 10.
10 or more.
Yes, 10 or more, sir. Yes.
Yeah.
And also about the prothrombin time, less than 18 seconds.
18 seconds.
Yes.
PT, less than 18 seconds.
Less than 18 seconds, and APTT less than 35 seconds.
Okay.
And also platelet, if platelet is more than 1,50,000.
Okay.
And fibrinogen level more than 180.
Okay.
180 gram per liter.
Okay. So these are the endpoints.
Yes.
For lab parameters wise, these are the endpoints for stopping the massive transfusion protocol.
So it's again the HB more than 10 gram per deciliter. If the PT is less than 18 seconds, APTT is less than 35 seconds, and if platelet transfusion if platelet count is more than 1,50,000, and if fibrinogen level more than 180. And if we have a TEG available, thromboelastography available, the following cut points can be used as a for transfusion. The following cut points can also be used. The plasma for R value, it's usually for more than 9 minutes. So if R value is...
So we have got the TEG, the rapid TEG,
Yes.
and then the ROTAM. Immediately on, like, even without getting these values, right? You basically you want to know what to transfuse.
Yes.
Whether you want to transfuse what cryoprecipitate or a plasma, platelet, whatever it is. Based on the diagram, you will be knowing based on the TEG diagram.
Yes.
I think we can take it on a separate class, the detailed evaluation of TEG, what to transfuse based on the diagram. We can deal on a separate class.
So they have told about the cut points for transfusion triggers, as if for plasma transfusion can be stopped if an R value is more than 9 minutes. Plasma or
Basically in TEG we have got few points.
Yes.
R value, K value, the alpha angle, then the maximum amplitude, then the LY30, the lysis time, the 30.
Yes.
So based on which one is affected, whether the R is affected or K is affected, the alpha angle is affected, you'll get to know what blood product to transfuse in case of a massive hemorrhage.
So in case of this R value is
But
mainly...
for that you need to know the diagram. So this TEG can come as a short note. Because it's an easy way to find out which one to transfuse. Even before the lab parameters come, no, you can transfuse.
So in the case of this R value, we usually is determining the plasma FFP, plasma transfusion. So if it is R value is more than 9 minutes, we can stop the plasma transfusion. If K time is more than 4 minutes, it's mainly for the plasma or cryoprecipitate transfusion. So that can also be stopped if K time is more than 4 minutes. If alpha angle is less than 60 degree, we can stop the cryoprecipitate and or the plasma transfusion. And if maximum amplitude, if it is less than 55 millimeters, we can stop platelets transfusion. And antifibrinolytics, like we can tranexamic acid, like such components, like we can stop if LY30 is more than 7.5%. So that is what is the parameter in TEG for stopping transfusion. If rapid TEG is available, they have told about this again for the plasma or cryoprecipitate transfusion if K time is more than 2.5 minutes. So as mentioned before, the K time was for 4 minutes in standard TEG. But in rapid TEG, if it is 2.5, and a cryoprecipitate transfusion can be stopped, or plasma can be stopped if alpha angle is less than 60 degree. As earlier also it was in 60 degree itself. And antifibrinolytics for LY30 more than 3%. Previously in standard TEG it is more than 7.5%.
So basically the TEG is all about the clot formation.
Yes.
So how much time it takes for the clot to form, and then how long the clot will stay like that, and how long will it take to degrade. Okay. So based on that only, because based on the various parameters in the blood, these values will keep changing. Yes. And you will get an idea, just like you read an ECG or ABG, just by reading the TEG, you know what is the problem here, what blood products to give, like that. Okay, it's easy way to understand.
So for the purposes of reporting and documentation, in the like for MLC purposes, they have told that hemorrhagic control or hemostasis can be declared when both of the following criteria have been met. The surgeon declares hemostasis based on the absence of bleeding requiring an intervention in the surgical field. So they have told that there is no bleeding requiring an intervention, or resolution of the bleeding after angioembolization. So if these both criteria are met in the that is the first point. The second point is that they have told that the surgeon and the anesthesiologist agree that the patient is adequately resuscitated based on the following criteria. If the patient is having a stable or increased BP, or if a patient is having a stable or decreasing heart rate, and also stable or increasing urine output, and also decreasing requirement for vasopressors.
Basically, a normalization of vital signs.
Vital signs.
And if the perfusion is adequate, which is suggested by increased urine output and increased GCS, everything,
yes,
we can stop.
Next is mainly about therapeutic agents in massive transfusion. The several agents mainly are available are antifibrinolytic medications, as told before, about tranexamic acid or aminocaproic acid, which usually inhibit the plasminogen activation and plasmin activity. Thus, they stabilize the clot. So, clot stabilization.
So the next question is when to give tranexamic acid in case of trauma.
Yes. Okay. So they have told that tranexamic acid 1 gram IV over 10 minutes followed by an infusion of 1 gram over 8 hours.
That is if the patient presents to you within 3 hours.
Yes.
After trauma.
Yes.
It's not like it happened 6 hours back and it came to you and you're not supposed to initiate. If the accident is within 3 hours, then you start on tranexamic acid regardless of wherever the bleed is. 1 gram IV
over 10 minutes followed by infusion
over 8 hours.
Yes.
Okay.
So that's what they have told out within 3 hours of injury. Okay. They have told that this platelet prothrombin complex concentrates, if available, they are mainly containing of 3 or 4 clotting factors. Prothrombin complex concentrate is mainly.
We have got a 4-factor PCC or 3-factor PCC also there. Usually it's given for warfarin, patient who are on warfarin and right now had a RTA and sustained massive requires massive transfusion
protocol.
Okay.
So the concentrates involved are 2, 9 and 10 or 2, 7, 9 and 10. So that are the clotting factors which are mainly
2, 9, 10 for 3-factor and 2, 7, 9, 10 for 4-factor.
Yes. So these are the mainly guidelines.
This can come as a question for a remark. Which factor is there in PCC, 4-factor PCC, 2, 7, 9, 10? Like that, they can confuse it. 1, 3, 4 like that. They can confuse it.
Yes.
Okay.
So these are the mainly the things they have told about. PCC is mainly used in the case of warfarin-induced coagulopathies, and they have told that refractory recombinant 7A. This clotting factor 7A is generally not recommended for the management of refractory hemorrhage in trauma.
What is
recombinant factor 7A is not recommended in the case of refractory hemorrhage in trauma. So they have told us specifically it is not recommended. And next is about the monitoring. What all things to mainly monitor in case of massive transfusion protocol. They must also they should review in the cases of massive transfusion with the following complications. The first thing is about a coagulopathy. So coagulopathy should be ruled out. Second is about the thrombotic complications associated, and also ARDS associated or transfusion reactions. TACO and TRALI, so transfusion associated volume overload or transfusion associated circulatory overload and circulatory overload or transfusion related acute lung injury or hemolytic in transfusion reaction, or if the patient is overly transfused with RBCs or death. So these are the complications can also occur in case of MTP. So these are there are also mentioned about some performance indicators during the process of massive transfusion.
So did you mention what is basically that massive transfusion? How much of blood should be transfused?
So that definition, sir, in the it is mentioned as in the proper trial. They are mentioned in the ratio of 1:1:1. But according to ACS, they have mentioned about 1:1:2. The plasma is to RBC ratio.
How units are
there is one. That's the ratio they have mentioned. They haven't mentioned about the volume. Volume, they have told that it is depending upon the volume required. So it is mainly based on the trauma surgeon, like discretion of the trauma surgeon, or based on the trauma volume of bleed.
Okay. It's not
and the hemodynamic parameters. So that is mainly what determines the volume of blood products to be transfused. They haven't specifically mentioned
like more than 10 units of blood transfusion. That's not there.
Yeah, no.
Is it there?
No.
It's not there. Towards the beginning.
No.
Okay.
Next about the performance indicators. So mainly the performance indications mainly involved the time for this following things are kept as a checklist. So these things must be always maintained in the case of massive transfusion protocol. Time from calling the MTP to the infusion of first unit RBC. That time they haven't given a cutoff, These things must always be kept as an indicator is what they have told us. And time from calling the MTP to the infusion of the first unit plasma, that time gap should always be kept minimum is what they have told. And adherence to the predetermined ratio of the between of the MTP.
The faster the transfusion,
the better
will be the outcome prognosis.
Yes, and also they have told about the wastage rate of the blood product. So these things must be mainly assessed is what they told about.
That's all.
Yes.
Can you show me the first page?
Yes, sir.
They have mentioned more than massive transfusion. They have mentioned more than 10 units RBCs in 24 hours.
Yes.
Yeah, in bracket they have mentioned here.
Yes, sir.
Okay, that is what is called massive transfusion.
Yes.
Massive transfusion protocol is different.
Different, yeah.
You are talking about massive transfusion protocol.
Yeah.
But when you call it a massive transfusion, more than 10 units of RBC should be transfused
Within 24
hours.
Yeah, in the protocol it's different.
that
Massive
is
transfusion means transfusion.
I was asking about that one. Really.
Yes, sir. Okay.